Good morning to everyone. On behalf of the Department of Anesthesiology, Medical College, Salem, I cordially invite. Are you able to hear?
Can you hear us? Can you hear us? Can you able to hear?
Yes, I'm hearing, sir.
Right.
Good morning to everyone. On behalf of the Department of Anesthesiology, I cordially invite our beloved Dean, Professor P. Shanmugam, MS, MCH, Dean, Annapurna Medical College, to preside over the functions. And also I welcome Professor N. Mohan, Medical Superintendent of Annapurna Medical College, Hospital, Salem. And also I welcome Vice Principal Professor P. Isha, Annapurna Medical College, Salem. And also I would like to invite our department professor, assistant professors, and the senior faculties of the department. And also I welcome all the members who registered for this webinar. I welcome you, sir. And also it is my duty to welcome our chief guest of speaker, Gauri Shankar, engineer MD. He is an assistant professor in the Institute of Surgical Gastroenterology and Liver Transplantation, Government Stanley Medical College in Chennai. I welcome you, sir.
Thank you, sir.
He is going to talk about the hypoxia and oxygen therapy. As you know pretty well, oxygen supply is less. What is mean by that? The hypoxia, how to treat all these, what are the modalities available to treat the hypoxia? Dr. Gauri Shankar is going to enlighten all the modalities available to treat the hypoxia. Once again, I welcome you, sir.
Now we invite our
Thank you, sir. Thank you.
Inspector Dean to take a few words.
Good morning to another respected Professor of Anesthesia, Dr. Pandian, the guest speaker, Dr. Gauri Shankar from Institute of Gastroenterology, Surgical Gastroenterology, the Stanley Medical College. Thank you for accepting to share your views with our faculties and the delegates. Thank you very much, Doctor, for accepting as an important topic.
Thank you. Thank you.
And respected medical student Dr. Mohan, and respected Professor Usha, Vice Principal, and the other faculty members of the anesthesiology, Dr. Raja, another professor, and the Dr. Satish, and all of the faculty members in the anesthesia department. I congratulate them for organizing this hypoxia and oxygen therapy. It's a much needed topic for each and everyone. This is the corona. So it has come to the highlight. All these years it was with anesthetists only. Anesthetists and surgeon only will always discuss this matter. So we always depend upon the anesthetist for all this. If you have a confident anesthetist on the head end, surgeon will do the job properly. So that is why the interaction between the anesthetist and surgeon is so important. And this hypoxia and oxygen therapy, it is all in the hands of the anesthetist during surgery. Such an important topic they have chosen, and I congratulate them for organizing this webinar. I wish you all the success. I think all the delegates who have taken part in this will benefit the speech by Dr. Gauri Shankar. He will enlighten all about the process of hypoxia and the oxygen therapy. Thank you very much for giving the opportunity. Thank you, sir.
Thank you.
Thank you, sir. Now I invite Professor Dr. Raja to give introduction of the speaker.
Very good morning to all the dais and off the dais. Now I am very happy to introduce Dr. Gauri Shankar, engineer, MD in anesthesiology. He finished MBBS in Tubings Medical College, and he finished postgraduate in the Canal Medical College. Now he worked as a senior assistant professor in the Department of Anesthesiology, Institute of SG and liver transplant in Government Medical College, Chennai. And his area of interest are liver transplantation and area management. And he achieved so many stones in the various received prizes in the quiz program, on conferences, and he presented papers also in the various conferences. And he is as a faculty as a speaker at various national and state conferences. And he conducted so many workshops in the medical college like simulation ACLS, focused assessment sonography, trauma, fast, and trauma elastography, and fiber optic bronchoscopy like so many workshops he conducted as a faculty. And he published 8 journals in the paper. And he is also very much interested in the social awareness program like brain dead donation and various schools and colleges. And now he works as an assistant professor and very happy to introduce the topic, and he will present the topic today, hypoxia and oxygen therapy. Now I hand over to this, Harish.
Thank you, sir. Now I request our Professor sorry, Dr. Panjan sir to chair the session, and I hand over the session to the guest speaker, Dr. Gaudishan, to start his session. Thank you.
Yeah, thank you. Thank you, Satish. I'm just sharing with the screen. Please let me know if you are not able to hear my voice.
You're audible.
Can I start?
Yes.
Yeah. A very good morning to one and all here. And due to the current situations and which have been entailing in the past 2 years, we have been ailing with these oxygen therapies and oxygen instruments and dealing with all types of hypoxia. And just want to highlight what are the things that we can do practically, and how we are going to identify what's happening in the lungs due to the oxygen deprivation. So just for the benefit of the students and other, as well as the residents, just I prepared a very simple PowerPoint to know and enlighten about the hypoxia and the oxygen therapy. So we all know that we all know that the oxygen tension, that is the partial pressure of oxygen, which is present in the room air, is about 160 millimeter of mercury, and that it enters into the human body, the lungs, and in the conducting airways, it reduces to 150. And comes to the alveoli, it's 106, and next to the capillary is 100, and the tissue is 55. And at the last, it comes to the mitochondria, about 7.5 to 40. So this decrease in the oxygen tension from 160 to 7.5 in the powerhouse of the cell in our body is known as oxygen cascade. That is many obstacles receiving from a 160 to 40 in the human body. So each thing, each one of the organs and each one of the tissues, each one of the blood vessels absorbs oxygen for their well-being. So there is a decrease in the oxygen in the cascade. In a normal human being, it occurs. So think about a person with having difficulties in any number of ailments, then the oxygen deprivation is here, and it will not at all enters into the powerhouse of the cell, that is a mitochondria. So that the production of energy will be lost. Actually, that in the tissue level, there is deprivation of the oxygen in the tissue level. Even though there is more thing that is coming, there is the complete absence or insufficient use of energy or insufficient use of oxygen in the tissue level. It is known as hypoxia. So what is hypoxemia? That we can able to see the oxygen level in the artery. That is the decreased partial pressure of oxygen in the blood. That we can see by means of the arterial blood gas analysis. So that is hypoxemia. So hypoxia is the reduced oxygen and insufficient oxygen at the tissue level, which can be utilized for that production. But hypoxemia is that the partial pressure is reduced in the oxygen in the blood, that we can see by investigations. So what are the effects of hypoxia? So we told that the oxygen being utilized at the last end in the human tissues and the cell is mitochondria. mitochondria. The oxygen, when it enters into the mitochondria, it produces about 32 to 38 ATPs, almost 38 ATPs, which is giving much power for our body. But about 8 is being used in the transport and other things. So totally 32 ATPs are being used, which gives a maximum storage of energy in the body. When the oxygen is absent, all the what it will do for the ATP is that by means of the glycolysis, the main production is the oxidative phosphorylases. But in case of absence of oxygen, it goes for the glycolysis in the substrate level phosphorylation. That gives only just 2 ATPs. It cannot be used for the energy cell. That is known in the cytosol, which being utilized in the anaerobic metabolism. So that leads into lactate and lactic acid and as well as the acidosis. So when there is absence of oxygen, there is acidosis, everything will get prevailed. So when there is oxygen, there's more amount of ATPs, that is energy production. So the effects of hypoxia will always lead to acidosis. Next, you can see the cell where the hypoxia prevails. The first and foremost channel which is blocked is the sodium potassium pump. It gets stopped here. So the sodium and the potassium will be functionally deprived. And there is the imbibition of the water molecules through the cell wall, because the cell wall becomes very fragile or frail. The water molecules get enter into the cell and making a blebs. So it gets swollen out. So what the next thing is that the walls get broken and it gives the lightening or the calcium, the channel gets started activated. So it reacts on the proteases, endonucleases, and hydrolytic enzymes. These are the nucleases which are used for the destruction of the cell, thereby leading the destruction of the tissues and causing the hypoxic effects in the body. So the mitochondrial level, everything, the ATPs are lost, and the potassium, sodium potassium channel is lost, and the calcium is activated, causing destruction of cell. And it is this programmed cell death known as the apoptosis. So what's the WHO, ICMR, and NIH, they classify what is an hypoxia? How do you define an hypoxia? By clinically, by the saturation with the pulse oximeter, the saturation of oxygen. During resuscitation, it should be more than 94. So when it is less than 94, you start giving oxygen. ICMR says less than 92 start giving oxygen, and NIH says less than 92 start giving oxygen. So what it's actually? So our target SpO2 should be 92 to 95. If it's less than 92, you start giving oxygen therapy. Even in 94 also, you can give a minimal form of the oxygen that can be utilized, that can be able to prevent the further consequences of hypoxia. And next, what do you see in the investigation charts is the PaO2, the arterial oxygen tension, and that is 70 to 90 millimeter mercury. If it is less than that, you're making a point to with the oxygen therapy. So coming to the some clinical aspects and some physiological behind what we are going to do is, now we want to know the arterial blood, how much of oxygen is in the arterial blood. The content of oxygen, it be calculated by the both the bound form of the oxygen with the hemoglobin and the dissolved form with the in the blood. So the bound form with the hemoglobin, this is the Hufner's constant that can be multiplied and the formula can be projected. So for example, when you say the hemoglobin is 15, the PaO2 is 100. That is the arterial oxygen pressure, ABG is 100. And in the pulse oximeter, you see a 98%. You calculate and put in the formula and we get the arterial oxygen content of 20 ml per 100 ml of the blood. So what it is that the in 100 ml of blood, you have a 20 ml of oxygen. Then what is oxygen flux? Oxygen flux is that the amount of oxygen that is delivered from the left ventricle per minute. So the cardiac output is 5 liters per minute. We already know that that is 20 ml of oxygen in 100 ml of blood. But for 5 liters of oxygen, 5 liters of the blood, this 1000 ml of oxygen, 50 into 20, the 1000 ml of oxygen is delivered from the left ventricle per minute. So out of which the 250 will be extracted by the tissue. So 750 will be prevailed in our body. So these are the things, how the oxygen being utilized. So we need to know the oxygen content of in the blood. Next, depending upon these hypoxias, we classify hypoxia into 4 types. One is the hypoxic hypoxia. This is the most common we've been dealing with in almost all the ICUs and almost all the ERs and all the casualties. And next comes to the anemic hypoxia. And third is the stagnant hypoxia. And fourth is the histotoxic hypoxia. We deal with one by one. One is the first one is the hypoxic hypoxia. The name itself reveals that the patient is in hypoxia. That is, the saturation is less than 92. You see the normal alveoli and the capillaries which is connected to the alveoli. There is oxygen getting diffused from the alveoli to the capillaries, and of course by the ventilation, carbon dioxide is getting into it. What are the defects we are going to see? In case of high altitude, there will be hypoxia. Ventilation defects in case of obstructive lung disease, you will see an hypoxia. And gas exchange defects, there's a capillary unit membrane. When there is a problem, you will see an hypoxia. So the outcome will be the partially bed that is not a completely oxygenated. So it is an hypoxia. So coming and you want to describe what is the streamline, what is the cause of hypoxia in this condition. So first one is you can see the alveoli of the lung and you give a cross section over that. This is the alveolar membrane. And in between the alveolar membrane is the basement membrane and this is the capillary membranes. So here there will be in high concentration and here will be the low concentration. By this one osmosis, the alveolar oxygen will be more here and of course the arterial oxygen will be here. So by means of high concentration, the oxygen will be delivered or imbibed from the alveoli to the artery. So by these pores, it can enters into the arterial oxygen. So what it infers, that is alveolar arterial pressure gradient infers is that the basement membrane or the alveolar capillary membrane unit is functioning good. If that is the gradient is the difference. There should not be any difference in the artery and as well alveolar and the artery. It should be a normal. Whatever coming here that is in the alveoli should get diffused and come to the artery. It should be the normal one. But some issues or some difficulties between the basement, maybe you can allow a difference of about 5 to 15. It should not be more than that. If it is more than that, then the alveoli is getting all the oxygen. It is not giving to the artery. That is the capillary. So it is not giving. So some problem in the alveolar capillary membrane. So coming to the hypoventilation, that is in case of if your patient is giving in post-anesthetic state or pre-anesthetic state, you're giving sedatives or analgesics or whatever thing. In case of in ICUs, you see a patient with a neuromuscular disorders, spinal cord disorders, the patient will ventilate now, will be in a hypoventilation. That is the less ventilation. But the oxygen, whatever they are receiving, for example, for a normal patient, you will receive 100 millimeter of mercury. But here in the alveoli, during hypoventilation, they receive 50% of it. But in the artery also, they're getting 50% of it. The diffusion is good. The alveolar capillary membrane unit is very good here because whatever coming in the alveoli will get into the artery. So in case of hypoventilation, the alveolar arterial pressure gradient will be normal. The one thing we have to treat is that give some oxygen, the patient will come out. So ventilation, when there is low, in case of sedation or neuromuscular disorders, give oxygen accordingly. So next is a cause for the hypoxia in the hypoxic hypoxia is the high altitude. When you go to the high altitude, people usually carry some oxygen cylinders with you. People usually you have an hyperventilation because of the FiO2 is reduced. No, there is no decrease in the FiO2. There is decrease in the barometric pressure. At the sea level, it is 760 millimeter of mercury of the barometric pressure. But when it get increases, you see if this is the peak of the Everest, you will get just 300 to 500 millimeter of mercury. The barometric pressure is deep. That causes the problem of hypoxia. That makes the TCO2 get decreased due to hypoventilation. If you give oxygen in this condition, people will come out very well. Here also, there is a normal alveolar arterial gradient. There is no problem in the diffusion point of view. So coming to the most important thing, that is the thing that we have dealt with almost 2 years in the COVID-19 pneumonia. It is a shunting. You see the alveoli is poorly ventilated. Before going to the shunt, you see some physiological dead space. It is normal because when the alveoli, the oxygen is coming, it is ventilating good, but there will be no blood flow in case of any shock. In case of low perfusion, there is no blood flow. Only the ventilation is being done, but the oxygenation is somewhat done by the other mechanism. So it is a physiological dead space. So ventilation without perfusion, that goes to the ventilation perfusion mismatch. So coming to the shunt, in the COVID-19, for example, you will have an alveoli flooded with the fluid, and the alveolar capillary membrane is thickened, and there is injury in the alveolar capillary unit, the alveoli being poorly ventilated. But the blood flow is good. What's the use of the blood flow with a poor ventilated alveoli? It will not take up all the oxygen from there to the capillaries or the blood. So there will be decreased oxygen. So how much ventilation and how much oxygen you give, there is no use at all, though the blood flow is good. So there is no use of oxygen because it is filled with exudate and edema fluids, and there is, of course, there is no use of oxygen in case of pulmonary shunting. There may be other shunt. Basically, shunt is that the oxygen or the gas that does not involve in the gas exchange, it is known as the shunt. There is the right to left shunt will be there, and there will be small veins shunting will be there, like bronchial veins, thespian veins, like coronary veins. But most common is the alveoli. When it is flooded with this, it will not give oxygen to the capillaries. So coming to the all these things we have seen, it gives the ventilation perfusion mismatch. In a normal body, when you're standing upright, you see the ventilation will be good in the apical part of the lungs, and ventilation will be bad, not bad, this will be less due to increased perfusion. Here the perfusion is decreased, the ventilation is good. Here the ventilation is decreased, the perfusion is good. So V is ventilation, Q is perfusion. The ventilation perfusion is increased here, but it is decreased here. So what's the important behavior is the compensatory mechanism takes part in our body, known as the hypoxic pulmonary vasoconstriction. You see there is an hypoxic alveoli, there is no, and there is a constriction in the blood. There is no blood flow here. So what it shows that the blood will not come here. It's in the normally ventilating alveoli. So what it infers that the alveoli which is good ventilating needs good perfusion so that the exchange will be good. When the alveoli is hypoxic or poor ventilating, there is no use of any perfusion here. That makes a compensatory mechanism here. So all this shunting, hypoventilation gives the ventilation perfusion mismatch. So that is to be corrected with the oxygen delivery devices. So coming to a flow chart, how we can segregate by which? By alveolar arterial gradient, that is the alveolar capillary unit integration formula. The hypoxemia, when you see the ABG and you derive this formula, it is easy. You can see in the app also. And if it is a normal gradient, of course, in a hypoventilation, give oxygen. The response will be good. Other thing is the V by Q mismatch. In the V by Q mismatch, you see though there is a widened gradient because the alveoli will be more, the artery or the capillaries will be less. So there will be V by Q mismatch or diffusion limitations. It also gives a response because V by Q mismatch in case of any atelectasis, any fibrosis or interstitial disease, the oxygen therapy like invasive ventilation will be giving a good result. But in case of shunting, there is no use of oxygen. That's what we dealt with the COVID-19. So next comes to the anemic hypoxia. Can you able to hear me? Can you able to hear me?
Yes, we are able to hear.
Yeah. Just I want to know that. Okay. The next comes to the anemic hypoxia. Here you see the alveoli. In case of the alveoli and the capillary membrane, that is the diffusion is good here. But the problem is anemia. That is, there is different type of anemia where the RBCs are the fault. The RBCs is dysmorph, dimorph, like that sickle cell anemia, thalassemias. And here the RBCs are malformations there. So the proper carriage of oxygen is not possible to the body tissues. And next is the carbon monoxide poisoning. In the also the RBC will be deferred, and there is no delivery of oxygen to the body tissue will be dismantled. So coming to why we are the anemic hypoxia is important is that you see the arterial content. You know the formula earlier itself by means of this is the bound form of oxygen. This is the dissolved form of oxygen. If hemoglobin is 15, a normal person with good PaO to 100 and saturation 98, you calculate this formula, the arterial content is 20. When you put the anemic patient with hemoglobin of 7 and put a formulation like this, you will get 9.5. See the 20 ml per 100 ml of blood and 9.5 ml per 100 ml of blood. There is a marked decrease in the oxygen content. But this cannot be evident by seeing the ABG. That is the partial pressure of oxygen in the artery by the ABG, because the alveolar capillary membrane is very good. The diffusion is all very good. But RBCs, which is taking the bound form of, there's a hemoglobin which taking the oxygen, will be very poor and very small. So that is the problem here. Coming to the stateless hypoxia in case of generalized shock, in septic shock and congestive heart failure, where you see the adequate gas exchange is here, but the blood going to the tissues will be slow. Less amount of oxygen will be delivered to the tissue for survival. Or maybe any obstruction of the blood in case of thrombus or any emboli, the blood flow will be reduced so that there will be less amount of oxygen delivered to the body. Last is the histotoxic. Histotoxic is that which says that the patient isn't having any septic thing, or the tissue level there is a malformations in the production house. In case of the tissue level, the cells will be deranged where it cannot utilize the properly bounded form of oxygen. That is oxygen alveoli and capillaries gives the bounded form of oxygen with the hemoglobin. But the tissues cannot utilize this one. There is a problem in the tissues. There is a problem in the mitochondria. So it cannot be utilized. As in case of cyanide poisoning, it obviously shows that it is blocks the cytochrome oxide system, which is present in the cell. And as well as alcoholic poisoning, in case it blocks the alcohol reaction. So though everything comes in a normal way, the tissue makes it defect in utilizing the utilization. So this makes the there is no use of oxygen here, because oxygen everything is coming. We have to treat this underlying cause. So how we are going to treat oxygen? When are the circumstances you are going to give oxygen? Is that cardiopulmonary resuscitation, respiratory failure, cardiac failure, of course, the full of water loaded in the lungs, shock of any cause, and carbon monoxide, increased metabolic demands, post-operative states like pneumothorax after any vascular access or any nerve blocks, and shortness of breath if ABG shows. Use the oxygen always as a drug. So if you use it on this condition, we can able to precisely use the oxygen and identify the cause, we can recover the patient. So what are the symptoms? We all know that there is shortness of breath, rapid breathing, and everything, confusion, excitement, everything. And later reading on to the signs like arrhythmias, bradycardia, coronary, HPE, pulmonary hypertension. And this all due to this carotid body chemotherapy that makes the puppet show. That is the bonds which having the nucleus, which having the respiratory center, which controls everything, the lungs, heart, external intercostal muscles, and the muscles which are used for respiration, that makes to act so that the accessory muscles get start acting, and the tachycardia occurs in the heart and the lungs. Because of the Herring-Beer reflex, it makes the hypoxia to be. So it all depends upon the respiratory system. So in the COVID-19, it seems an entirely different thing. Just to add it upon that, the shunting is more important here, and carbon dioxide retention, dead space ventilation, lung capacity is very poor. It takes a long time to identify a patient with distress. So initially we used to give an oxygen. So that's why we are always in an happy hypoxia. The latent period is increased here to identify and treat a patient in a COVID-19 pneumonia with hypoxia. So how we are going to monitor a hypoxic patient? Of course, you see a monitor with a pulse oximeter showing less than 92. If this shows, immediately start an hypoxia. Next is hypoxia treatment. Next, you have to take an arterial blood samples for APG. Then you decide by seeing these values. Patients with the pH less than 7.5, CO2 is increased, PO2 is less. So start giving initial forms of hypoxia. Oxygen therapies to this patient. So ABG is very essential. From the ABG itself, you can able to analyze the alveolar capillary membrane, the gradient. So by which we are seeing that alveoli and as well as capillary is good by seeing this ABG. So ABG, next most important is the PF ratio. How the the arterial oxygen, the FiO2 what you are taking. The normal is 300 to 500. The less than 300 shows there is a poor exchange. If it is less than 200, we already know it is an acute lung injury and ARDS sets in. So PF ratio is very important by seeing the ABG. So coming and giving oxygen of about just 5 to 10 liters, we are heading with a huge number of work behind to get the oxygen by storage, transportation, again storing in the hospital, the manifold, again sending all the cylinders in our and getting into the pipeline system. We used to get the oxygen. So we have to remember all these things are happening behind us to get just a little amount of oxygen. So of course, almost all the oxygens almost all the hospitals are flooded with the liquid plants and oxygen manifolds. So coming and deciding upon the oxygen devices, we need to know the peak inspiratory flow rate. That is the demand of the patient. See, for example, a patient is taking a tidal volume of 500 ml with a respiratory rate of 20 per minute and IE ratio of 150. In 1 second, he used to take 500 ml. For 60 seconds, almost a 1 minute, he's taking 30,000 ml. That is 30 liters per minute. That is the peak inspiratory flow rate. A device which matches this peak inspiratory flow or which gives this peak inspiratory flow rate is a high flow devices. And which doesn't give this one, it's or less than that, it's a low flow devices. And the high flow devices which gives a fixed oxygen, whatever oxygen FiO2 are giving, amount of FiO2 is delivered to the patient. They are known as fixed performance device. And when it is less than that of FiO2 is the variable performance device. So by depending upon the patient's demand, depending upon the peak inspiratory flow rate, it is the oxygen device are divided into fixed and the variable performance device. For example, is the initial and most simple method to treat an hypoxia about 94 to 82. We can see the patient in case of a mild hypoxia, you give a nasal cannula. This is a variable performance device. It's very simple. You connect this nasal cannula into the nostrils and connected with the hood in the ears are connected in the back of the head. And this you can give the flow rate of about 4 liters and it gives an FiO2 of 24 to 45%. You see the cannula, which is the connect. Here is the nasopharyngeal space. This is the anatomical dead space occupying about 50 ml of whatever gas get coming into. So if you give oxygen through this, 50 ml will be collected and in the next inspiration, the 50 ml get enters this. And patients also, somewhat mouth breathers will also, the room air, the atmosphere air get enters. They get mixes here. So the FiO2 for 4 to 6 liters will not be delivered as we presume. It gets diluted by the environmental air mixture. So it is a variable performance device. Whatever we are seeing will not be delivered to the patient. And if the patient is having the oxygen here and there will be some amount of carbon dioxide collected here, patient will have the problem of rebreathing. The most important thing is that when the patient is active, is talking, walking, or is eating, this will be very helpful. The problem will be that the crusting will be there when you have a prolonged period of about 24 to 48 hours. There will be crusting. And if you pick, then epistaxis will come. So very careful. You're giving more than 4 liters, you humidify the oxygen, and then you give by the nasal bronch. And if there is any polyps or septal deviation, that will be difficult for us to gain the FiO2 of 24 to 40. Coming to the most important thing that we use is the Hudson's face mask or simple face mask. You see the face mask with having an exit holes here. The patient breathes and the oxygen comes out. That is a carbon dioxide somewhat comes out, but it entrains the atmospheric air into this mask. So some amount of air gets entered into it. So it is not a fixed one, it is a variable one. The flow meters that we keep here is about 5 to 8 liters, maximum 10 liters we can keep. So by this one, you give it's a variable performance device. Whatever thing you're keeping more than 4 liters, you give a humidify the body. So in case of this, this is also the same as that of the nasal cannula. You have an anatomical dead space. There will be a rebreathing thing will be present. This is simple face mask for a mild hypoxia about 90 You can keep this one. Patient can come out if you rectify other. Next comes to the fixed performance device or a high flow systems like Venturi mask. The Venturi mask you all seen in case of the moderate to even severe hypoxia. Different types of cannulas being used. That will be depicted how much liters of oxygen can be given and how much percentage we can get. Here and everything will be written here and you will get percentage. How it works by the Bernoulli's theorem. When the port size is big, the flow will be good. And there is a lower FiO2 from the that is the less amount of oxygen being entrained in the atmosphere. So the more air is entrained here, there will be high flow and it dissolves the predetermined FiO2. So it also gives higher flow very less. So it will be useful when it is less than 10 liters per minute. So how we are going to calculate the FiO2 which is delivered by the Venturi mask. You're giving the about 15 liters, you're connecting the patient with an Venturi mask about here. You'll get a 60% of oxygen being delivered here. See, the oxygen flow is 50 liters per minute. Air entrainment will be 15 liters per minute. Total flow will be 30. But in the air, how much oxygen will be there? It is only 3 liters according to the hypothesis. So 15 plus 3 liters is 18 liters. So 18 out of the 30 liters will be the 60%. That is the FiO2 calculation for an Venturi mask. This is a fixed device, but in case of higher flows, it doesn't depend upon us. It depends upon the device itself. So coming to the non-rebreathing mask, which is routinely we've been using for a severe COVID-19 and even moderate cases. So in a non-rebreathing mask, the simple Hudson mask is being designed in such a way so that there is no rebreathing. So see how it works. You keep a flow liters should be more than 10 so that there is no rebreathing. Keep around 12 or 15 liters. And you have to make the bag to be get filled. The bag should be at least 1/3 should be filled. The reservoir bag about 300 to 500 ml should get inflated before keeping the patient. Now it is inflated. You see the inflation. So this oxygen which is collected here only will get enter into the patient's air, which is get collected. And you see the valve here. Earlier we see an Hudson mask. Now we are seeing a valve in the exit port. This valve makes the expiration come out immediately and there is shut off. It will not allow the environment to get entrained into this. So that's why there is a fixed FiO2 being delivered and it is an high flow device. There is another valve here which get closed when the patient expires. When the patient inspires, it gets open and the oxygen in the reservoir bag get enter into it. And at the end of in the reservoir bag, there should not be kinking or knotting. There is no use of it. So you have to verify that the passage is so that the oxygen in the reservoir bag get enters it. So how much FiO2 that you can get is that about 90%. And next is the high flow nasal cannula, which is a heated humidifier. So this is the high flow system where we can give. We have a chamber here where you can connect the humidification process. The oxygen is get connected and the humidifiers is get connected and you have a water chamber that is connected to the oxygen pipeline. This pipes will be having the thermal sensor wires that will make or prevents condensation. So you see the oxygen being connected through this and if some amount of environmental air also enters into it. So it mixing of air occurs and later it makes a blending here. This is air oxygen blender which is inside and so that it gets collected in the humidifier process, that is the thermal sensing unit where the molecules are then connected with water molecules and humidified, heated, and then it passes over the tubings. So this is then connected and here. You see, this is the heated insulated tubings where the oxygen is given with this one. So this is the port which sends whether it is thermally sensitive and to prevent any after effects of unavailable humidification in the nasal passage. You have the nasal prongs here, which is connected, which will be very useful when the patient is active, but having an hypoxia in case of an happy hypoxia, in case of COVID-19. So we achieved, and we can see some patients with the normal low flow nasal cannula with NRBM connected. Both these are connected. You see the thing that is the result almost equal to the high flow nasal oxygenation. So we have seen in this almost all the patients with in both these one in our COVID scenario. Next comes to the some mechanics that can make in the lung is a BiPAP or a CPAP. You see the patient with having normal breathing and it's a CPAP. In the CPAP, you give some amount of positive end expiratory pressure is given in a spontaneously breathing patient. This is the CPAP. What is BiPAP is that there are two set of pressures. One is the low pressure is that EPAP, that is in during expiration, it makes here, and during inspiration, it is an IPAP. So inspiratory pressure should be kept around 10 centimeter, and expiratory pressure is almost like a peep, it is 5 centimeter of water. This is a BiPAP. This is a BiPAP mission that we use. So you already know how we are giving, that is a constant pressure both during the inspiration and expiration. In case of patients with OSA, we can treat patient with severe hypoxia, we can treat CPAP, which we use for mild pulmonary edema and post-operative states where the patient is coming out from the anesthesia. We can use this one. So these are the things. In case if you're not giving adequate in the CPAP and BiPAP, you go with this NIV mode of. So such hypoxia which is not corrected by all these mechanisms, all these devices to intubate and ventilate. Something about the concentrators. This is about weighing out 4.5 to 5 kgs, which will be driven only by the electricity. We're having high humidity and it cases a reduced efficacy. So it is a commercial use. If we are not available with that of the hospital pipeline system and hospital liquid storage system, we can use this concentrator only in case of mild cases, about 5, but somehow 10 liters are coming. But it used for mild hypoxia, it will be much used. When the power electricity is lost, there's no use of this one. And the hyperbaric oxygen, the one end is very low oxygen. Here is the higher end of oxygen. 2-3 times of the barometric pressure of oxygen being delivered or pushed to the patient's body. The patient is in severely diabetic sepsis. There is in the tissues and the muscle necrosis. All these conditions, we can give an hyperbaric oxygen, which gives a good results in those patients in the sepsis. And though we are giving a huge amount of hypoxia, patients long term of hypoxia have many after. So you see the mask being fitted for a non-invasive or BiPAP. There will be a necrosis, a pressure trauma, or over the injury over the eyes. And you see then absorption atelectasis in the lungs, and fire explosions are common. In the children's, when you give a huge amount of oxygen, retroventricular fibrillation is more common. And nowadays, we are seeing more patients with mucormycosis, probably due to the uncontrolled oxygen therapy and there will be oxygen toxicity. And again, along with uncontrolled diabetes and as well as the increased use of the steroids. So causing this. Thank you. So hope you understood what's the basic things of hypoxia and as well as the after effects of the hypoxia.
Thank you. Thank you.
Thank you. Hope there is no any interference. There is no any disturbances during my talk. I'm not sure about that. I'm just talking on my thing.
Yes, okay.
It's very clear.
Yeah.
We should thank you, sir, for giving the explanation about the hypoxia and its various methods to treat the hypoxia. Thank you very much. It's useful not only to the our medical people, but also it's very useful for the non-clinicals and non-medical also. What is hypoxia? Thank you very much for.
Thank you, sir. Thank you.
Audience, please.
Any questions from the audience?
Yes, sir. One person. Dr. Major from finish.
I received on a question.
Yes, sir. Yes, sir. When to decide that patient needs to be changed to CPAP?
In when the patient actually when you are seeing that a patient with oxygen therapies with oxygen mask like NRBM or a normal mask, you see the thing by clinical conditions when there is an increase in the respiratory rate, or by the ABG when there is a partial pressure of oxygen is getting decreased, or you see the some changes in the mentation going for any hypoxemic effects in the brain like encephalopathy. In that change, that is in the transient period, if you change into CPAP, the patient will be better. Even in the CPAP, the patient is having hypoxemic still and encephalopathy features like restlessness, confusions, delirium. Of course, the oxygen in the brain will be less. So in that condition, you have to invasively intubate and vent. I think the CPAP is the changeover to the CPAP is basically depends upon clinical condition, and to confirm it, we'll do an AMCH.
One more question. And if COVID, we cannot intubate, what to do?
So in case of COVID, usually we won't intubate unless the thing that it's going out of hands, like increased respiratory rate and in encephalopathy, that is hypoxic encephalopathy conditions. Only thing we have intubated in the last 2 waves. And in the last wave also, we used to intubate some of the patients, about 5% the patient came out very well after intubation. So if you can't intubate, you can make a modifications in the CPAP or a BiPAP by giving your supplements of drugs in a COVID patients. So the mechanics can be altered with the CPAP by in the non-invasive ventilations. Like in a BiPAP, you can increase the inspiratory pressure, or you increase an EPAP. The PEEP can be increased accordingly. You have to monitor by the ABGs, and you decide. You can make the changes or change the mechanics in the CPAP or IPAP if you are not going to intubate. If you are intubate, of course, there is a number of modes to decide to make the lungs to modify accordingly.
Okay. So simple. In COVID era, now so many articles coming because of hypoxia. And everyone is only knowing SpO2 94, 92, 96. And some more articles coming that the SpO2 depends upon the age of the patients. The target SpO2 will change depends upon the age of the patient also. Is there any relation to the hypoxia and the age factor? Now the government also frequently changing.
Yes, sir.
Yes, 94 once before 96, now 94. So any target SpO2 is related to the age of the patient.
Yes, sir. So actually, of course, there is a changing situation in COVID. In the first COVID wave, we usually kept our target SpO2 was 94. When a patient without any distress, but is having COVID symptoms like cough, cold, like everything, coming with a saturation of 94, we just keep a nasal bronze. That's it. 94. When it is now in the second wave, we keep the target wave as 92. In the 92 also, we keep a nasal prongs. If the nasal prongs kept, it comes around 96. That's all. If even the patient not tolerating well with the nasal prongs, we immediately jump on to the non-rebreathing mask. The non-breathing mask can be given even with the patient's saturation of about 88. We'll give a non-rebreathing mask. Somewhat it can present and manage around 94 saturation. If the patient is coming with the symptoms like respiratory distress, with the increasing respiratory rate and a hypoxia showing about saturation of 70, we initially start with NRBM only, not CPAP. If NRBM is the first charge of less than 80, if we are seeing whether he is settling with the NRBM and other drugs like low molecular heparins and other steroids, if it's not settling with that NRBM, we switch on to CPAP immediately. If the patient coming with respirator of more than 45 and his distress is evident and is in a confusion and delirium states, we make him connect to the CPAP, immediately receiving the IC. Whatever may be the saturation.
Question is, what's the target SpO2 in pediatric age group? Person is asked, Dinesh Dimraj.
In a pediatric age group, we never take a chance. If there is no symptoms, even there is no symptoms, when there is a saturation of less than 90, we will give oxygen therapy. In pediatric age group, we will not take any chance of getting saturation of 92 or 94 like that. Even 96 will be the target saturation. If the patient very distinct showing an accessory muscles acting or some other investigations showing a coagulation profile like D dimers increasing, ferritin increasing in a pediatric patient, we immediately start with the minimal with an NRBM or a normal Hudson mask. If the patient is in distress, we definitely go with the nasal CPAP. It's that what we have used in the second way for a pediatric patient.
Any more questions? No questions. We can finish this. Now, Satish will talk about the vote of thanks.
Good afternoon all. I thank our HOD Professor Dr. Pandyan for giving this opportunity to propose vote of thanks on behalf of our department. First of all, I would like to express my gratitude to the guest speaker, Dr. Gauri Shankar, who is my undergraduate batchmate, who has readily accepted our invitation amid his busy schedule for delivering an excellent speech on hypoxia and oxygen therapy and enlightening us. And a special thanks to our respected chairman, Mr. J. Satish Kumar sir, who has been a driving force behind all our endeavors, and especially during this pandemic period, has helped us to continue our academic programs through webinars. I would like to thank our Dean, Professor Dr. Shanmugam for presiding over this webinar. I would like to thank our dignitaries, Medical Superintendent Professor Dr. Mohan sir, DMS Professor Prasanna Babu sir, Vice Principal Professor Dr. Usha ma'am for their constant support. I would like to thank all faculties, students and CRS of AMCH and other delegates who have actively participated in this webinar. And I kindly thank our Panchacharam team and the IT team and the non-teaching staff of our department for their technical support. Thank you. Thank you, Nandal. Thank you, Gauri Shankar, for your excellent speech. Thank you.
Thank you, Satish, and thank you, sir, Dean, and Head of the Department of Anesthesia and other faculties of Annapurna Medical College. I'm very thankful to this for giving me this opportunity. It's a nice thing to interact with this and nice to share my experience about the oxygen therapies that what we did in the last 2 years. Thank you so much.